Thank you, organizers, for having us here today. I'm going to be doing a rapid review of 6 abstracts to set it off. This is the first one, which looks at the 15-year-old overall survival results of adjuvant capecitabine for early breast cancer, and this was published in the JCO. And the main purpose of this study was to look at the influence of adjuvant capecitabine for long-term survival of patients with early breast cancer, and this was the results of the Finland capecitabine trial called FIN-XX. This evaluated addition of capecitabine to an adjuvant chemotherapy regimen which consisted of docetaxel every 3 weekly as a combination of docetaxel capecitabine followed by cyclophosphamide, epirubicin and capecitabine. So there were 3 cycles of docetaxel capecitabine followed by 3 CEX every 3 weekly, and this was compared to docetaxel followed by CEF 3 weekly. 1,500 patients with node positive or high risk node negative early breast cancer were evaluated, and a median follow-up was of 15 years. So the 1,500 patients were randomized equally into both the arms. Finally, when we look at the intention to treat population, 751 in the study arm and 744 in the standard arm. 171 patients in the study arm died during the follow-up as compared to 204 in the standard arm. So we look at about 22.8% mortality in the TX-CEX group and 27% mortality in the TCEF group. And the overall survival being significantly longer in the arm where capecitabine was added as compared to the standard docetaxel followed by CEF with a significant p-value. When we look at the various subgroup analysis, patients with ER negative cancers and those with HER2 negative cancers treated with the capecitabine arm tended to have a longer survival. The 5-year, 10-year and 15-year survival rates were 88 versus 75, 81 versus 69 and 74 versus 64 in favor of addition of capecitabine. So the conclusions were that the addition of capecitabine to a chemo regimen that included docetaxel, cyclophosphamide and epirubicin improved overall survival in a patient population during this median follow-up of 15 years. And this adjuvant capecitabine addition could be considered as an option for some patients with early breast cancer. There are certain limitations, however. The study had a primary objective of relapse-free survival, which was not analyzed as per the protocol. The follow-up of the patients was generally limited to the first 10 years after the date of randomization at the study sites, and therefore there were certain recurrences which could not be captured with certainty. Most of the countries had 100% registries for death, so death was completely captured. My conclusions is that we've seen that adjuvant capecitabine had shown improvement in overall survival in the AC followed by T versus AC followed by TX adjuvant trial, and this was published way back in 2015. We know that by addition of a daily dosing of capecitabine, we are intensifying the dose of 5-FU and capecitabine, and the similar kind of benefit has also been seen with dose-dense regimens in triple-negative breast cancer. The addition of platinum agent in adjuvant for TNBC does remain a controversial topic with a questionable benefit and increased toxicity. Capecitabine benefit in BRCA-positive TNBC versus olaparib has not been really studied, and the role of capecitabine in PDL1 positive TNBC in patients who have post-neoadjuvant immune checkpoint inhibitors also remains unanswered. The second paper is to look at the effect of denosumab added to 2 different nab-paclitaxel regimens as neoadjuvant therapy in patients with primary breast cancer. This is the JEPAR-X, which is a 2x2 randomized clinical trial. The background is that adjuvant denosumab might improve disease-free survival in hormone receptor positive primary breast cancer, and there was a need to actually look at what is an optimal neoadjuvant nab-paclitaxel schedule in terms of efficacy and safety. So mainly to determine whether addition of denosumab to the anthracycline taxane containing neoadjuvant chemotherapy regimen increases the PAT-CR rates, it was the main purpose of the study. So this was an open label phase 2B 2x2 randomized clinical study conducted at 38 sites between Feb of 2017 and March 2019. Patients had a unilateral or bilateral primary breast cancer with a stage of T2 to T4 or clinically T1C also. They had to be clinically node positive or pathologically node positive, or having hormone receptor negative disease and a Ki67 HER2 negative disease or Ki67 more than 20%. 778 patients with early breast cancer were randomized into these arms. The first arm looking at addition of denosumab versus no addition of denosumab between the regimens, and the second arm looking at two of the NAP paclitaxel infusions, one given every weekly at 125 per square meter, and the other one given day 1, day 8 at the same dose, with the third week being a gap. So 799 females and one male patient were included. PATH CR rate was 41% with the denosumab arm and 42.8% without the denosumab arm, irrespective of the subtype. The weekly NAP paclitaxel resulted in a significantly higher PATH CR rate of 44.9% versus 39% as compared to the day 1, day 8, 3 weekly schedule. The PATH CR rates for NAP paclitaxel schedules were only significantly different in the TNBC subgroup, and the non-hematological toxic events of grade 3, grade 4 were higher with the weekly NAP paclitaxel arm. So this was the first study which investigated denosumab as a part of NACT, offering head-to-head comparison. Weekly application of NAP paclitaxel was more effective than giving it day 1, day 8 every 3 weekly. Addition of carboplatin in the TNBC arm, which was allowed in this study, resulted in a PATH CR rate of almost 60%, and the addition of denosumab to an anthracycline taxane-based chemotherapy did not demonstrate increase in PATH CR. So when we look at the adjuvant zoledronic acid data in the hormone positive disease, it has shown improvement in survival, but there was no benefit when it was added to NACT. We've seen that with the NAP paclitaxel weekly regimen, the peripheral neuropathy is a very debilitating adverse event which affects the quality of life. In this study, 30% patients had resolution of grade 3, grade 4 peripheral neuropathy to grade 1 prior to surgery, but there is no data about what happens to them post-surgery and follow-up of the peripheral neuropathy afterwards. The higher PATH CR rates in the weekly regimen need to be weighed against potentially high risk of adverse events. The third one is about concurrent olaparib and radiation therapy in patients with TNBC. This is the phase 1 olaparib and radiation therapy for triple-negative breast cancer trial. We've seen that TNBCs are sensitive to PARP inhibitors, and these can be used as radiation sensitizers, and the objective of the study was to assess the safety and tolerability of PARP inhibition with olaparib used concurrently with radiation in patients with TNBC who had residual disease after neoadjuvant chemotherapy. So this was a dose escalation trial. The dose were increased in 50 milligram increments, starting from 50 milligram twice a day to 100, to finally reaching to 200 milligram twice a day, which was the tolerable dose without dose limiting toxic effects. Olaparib was started 1 week before radiation and was continued all throughout the radiation, and as per standard 50.4 grays was delivered to the whole breast. Main outcomes were the safety and tolerability of the PARP inhibition along with radiation, and when we look at the results of the 24 patients who were included in the trial, there was no dose limiting toxic effects seen till the dose was escalated to 200 milligram twice daily. No late treatment related grade 3 or greater toxic effects were observed on a 2-year follow-up period. The 3-year overall survival and event-free survival were 83% and 65% respectively, and the HRR status was not associated with any improvement in overall survival or event-free survival. So this dose escalation trial suggests that PARP inhibition with olaparib is well tolerated and it can be further evaluated in clinical trials. We know that this is a limited study. We need a larger study to look at differences between the hormone HR proficient versus HR deficient population, and role of such a strategy in patients who are chemo-resistant TNBC should definitely is a hypothesis generating at present. The next one is velaparib monotherapy following carbopacli plus velaparib combination in patients with germline BRCA-associated advanced breast cancer. This is an exploratory analysis from the Brocade-3 trial, and this publication in Annals of Oncology looked at a subset of patients which had discontinued carbopacli before progression and those who had continued on olaparib, on velaparib or placebo maintenance as a monotherapy until progression. and this subgroup analysis was presented here. This is the schema of the original Brocade 3 trial, which is a 2:1 randomization. Patients randomized to velaparib plus paclicarbo. They are treated till progression, and if paclicarbo were discontinued prior to progression, dosing of the PARP inhibitor or placebo was increased to 300 milligram BD continuously and then 400 BD if tolerated. And the primary endpoint was PFS, with secondary endpoint being overall survival, clinical benefit rate, and overall response rates. So 509 patients, totally 337 on the velaparib arm, 172 with the chemo alone. 136 of these 337 and 58 of 172 had discontinued both carbo and pacli before progression, and they continued to receive blinded PARP inhibitor or placebo as monotherapy. Most of the baseline characters were well matched. There were lower proportion of patients with liver and lung metastasis in the monotherapy group. There were higher proportion of patients with having a good ECOG performance status. We see that in the mean exposure to carboplatin, it's 11 cycles in patients who were on the PARP inhibitor compared to 10.6 and almost 10 cycles each for the paclitaxel. And most frequent stopping time for paclicarbo was at 6 cycles, and this analysis includes patients who were in CR or PR alone. Now this, on the left hand side, the chart A shows PFS analysis of the intention to treat population, and on the right hand side, the chart B shows the PFS in blinded monotherapy subgroup, which shows a hazard ratio favoring the PARP inhibition with an investigator assessed median PFS of 25 months and in the velaparib arm and 14 months in the placebo arm. There were certain issues regarding the PFS analysis, which actually exhibited a delayed separation between both these treatment groups. So they used a modified Cox model using time-varying covariate analysis, and this is on basis of the table which is mentioned. The first table shows the time-varying covariate analysis in the PFS, looking in the monotherapy as well as the combination arm. And we see a hazard ratio of 0.49 in the monotherapy phase with the PARP inhibition. When we compare patients who have stopped chemo at 6 cycles versus those who have continued between 7 to 12, there was no difference in terms of any change in the hazard ratio seen favoring the velaparib inclusion. So the PFS benefit observed in the velaparib arm was derived both due to the combination as well as maintenance therapy. The safety data indicates that the safety profile in monotherapy is very consistent with what are the known adverse events. This data, of course, is a post hoc and exploratory nature, and PARP inhibitor maintenance after a fixed duration of platinum therapy could be a way by which we can provide clinical benefit to these patients. However, we've seen that the comparable PFS benefit is there if chemo stops at 6 cycles versus continuing 7 to 12 cycles. Maybe we can reduce the chemotherapy load in these patients, thereby decreasing the adverse events related to it. There was an improved PFS with velaparib monotherapy, so thus it becomes a non-cytotoxic option. And the PFS benefit actually is in super selected patients, so currently we cannot generalize this at present. The next one is treatment with irinotecan pegol for patients with metastatic breast cancer and brain metastasis. These are the results from phase 3 ATTAIN study. And irinotecan pegol is a long-acting polymer conjugate of the topoisomerase 1 inhibitor irinotecan. We've seen the BEACON study results actually led to this ATTAIN study design, and BEACON study was a phase 3 open-labeled multi-center study of looking at EP versus TPC. These are treatment of physician's choice in patients with heavily pretreated metastatic disease. Was initially an 800 patient data, and from the BEACON study 67 patients were actually looked into, and this became a starting point for the ATTAIN study, which was a phase 3 open-labeled study which was randomizing 220 patients 1:1 to irinotecan versus treatment of physician's choice, and treatment was until disease progression. 178 patients enrolled. Treatment of physician's choice was variable, eribulin, nab-paclitaxel. The median duration of exposure was 1.4 months versus 1.6 months, and 22% patients in the irinotecan and 10% patients in the chemotherapy group completed 7 or more doses. There was no difference between treatment groups. Subgroup analysis did not show any difference between any of these groups as per what the subsets were. So the trial conducted actually confirms results from the brain metastasis subgroup analysis in Beacon. The trial actually did not replicate the positive overall survival benefit of treatment with irinotecan when compared with chemotherapy. We know there were differences between them. More patients with TNBC were present than the Beacon brain metastasis group. Fewer patients had prior whole brain radiation in ATTAIN versus Beacon, and more patients had received eribulin-containing regimens in them. So in conclusions, the difference in standard of care needs consideration and hypothesis generating at present. Thank you very much.